I do have some slides. I'm David Maxwell-Jolly. I am a recently separated employee of the HealthCare California. I'd like to begin with a disclaimer that I cannot be expected to speak for them, and they are poorly capable of speaking for themselves. However, I have in the past couple of years been the chief deputy there, and I'll be presenting a discussion today. I separated from the state, and I retired at the end of the last year, and after 31 years working for the state of California, it was a good opportunity for me to reflect on how vast the change there has been within the landscape in California. When I thought back of my first days with the state, we had a young governor. His name was Jerry Brown, and right then that summer, just before I started with the state, we had shifted responsibility for childless adults in the Medicaid program back to the counties. I think there were disputes between counties and the state about financing, about all kinds of things. Of course, that's not changed, has it? In addition, we had water shortages, I think. And interestingly, we embarked in Medicaid on the selective provider contracting program, which was a program aimed at saving costs in the Medicaid program by selectively, by limiting the network of the hospitals that was delivering health care under the Medicaid program. Suffice to say, the more it changes, the more it stays the same. One different aspect of this is the Affordable Care Act. I think that we are on the dawn of some fundamental changes that are really going to make profound changes in how we are covering people and how we are financing health care across California and certainly the nation. I want to focus on California. You've seen all of these reforms enumerated in various ways today. I don't want to go over them again. I do want to point out that within the individual small group market, California had a guaranteed issue program for small business already. The changes there are not quite so profound as they might be in other states. But I'd like to emphasize the last two bullets here. First of all, Medicaid expansion. As Toby mentioned, the Affordable Care Act saga over the last 3 years has been not just a saga about the marketplace or the exchange. It's been a saga about Medicaid and the marketplace. The efforts to launch in California have depended fundamentally on the intimate collaboration between the exchange agency and the Medicaid agency. And I think one of the foundations of our success has been that partnership. The second thing the Affordable Care Act did is it provided us a lot of money to develop the infrastructure that's necessary to pull off this kind of coordinated marketplace. And that investment is something that we would have been hard-pressed to come up with in California on our own. But it will, I believe, lay a great foundation for the future of health coverage statewide in all aspects of health delivery and health coverage. What I'd like to do today is talk a little bit about status where we are, how we're doing, but I'd also like to talk about what the future holds, where we're going to be going. And I think a good basis on which to discuss this is to look at the mission, the self-declared mission of the Exchange Board, and look and see what they say they want to do and what they're going to do. Because some of these bullet points in their mission are yet to be achieved. Increase the number of Californians with health insurance, of course, reducing uninsured. The second one is to improve quality. Third one is to reduce costs. Two objectives that are probably a little at odds with each other. And the final one is to try to make more equal access, to reduce the disparities in health coverage and access to health services throughout the state. So let's take these things one by one. Where's my, yeah, look, I did it, yay. Okay, increasing health coverage. This has been the fundamental leading goal of the mission, and as you have heard, relative to other experiences of other states, we had our launch has come on sooner and with a little less bumps in the road than a number of the other states and certainly the federal exchange. I like to say it's it's an ordering of relative miracles. The fact that we could, in the period of time available, launch anything here that would actually enroll people, given the time that was available, was a miracle. Ours was a little more a higher performing miracle than the miracles that other states and the federal government were able to perform. And I have a long experience in large IT system implementation at the state level, and I know what takes a miracle, and this one took a miracle. Here's a little bit of the saga of our intro. We didn't know what was going to happen when we opened the doors on October 1st, and in fact, I left off the first 2 weeks because they were, like insane chaos. The first day we had 1 million contacts or something. But what we were riding through this launch period, every day working to improve the performance of the website, every day kind of looking at the numbers. 50,000 applications, 50,000 people making applications was not very cheerful for us because it really wasn't going to reach our goals, and we were getting kind of worried. Well, it turns out everybody was listening to the national media, and I think, and they were being told, well, it's not going to work until December 1st, so don't worry. So on December 1st, it hit the fan. I mean, we every day, if you look on the applications, every day of every week, we got more applications the previous day. Every week, we got more applications the previous week. Totally mounted up to the end of December until finally we had a kind of Christmas hiatus. The other thing that was going on here, and it was that people were getting termination notices. In California, what we did was the exchange had a condition in the contract with participants of the exchange that they could not continue non-compliant products after January 1st. And when all the controversy erupted in Washington, we looked at that issue, and in California, the board itself decided that it would not overturn that policy. So we in fact took our medicine with respect to non-compliant plans immediately, and a whole bunch of those people coming in here in December were people who had gotten notices from their plan saying, your plan is ending. Here's what we suggest your new plan is. Apply Covered California if you want to see some other things. And so a lot of the activity that we got in those early days was, in fact, people in the existing marketplace coming in to getting a substitute plan in Covered California. So what you have to be successful in enrollment, reduce an insured level, you need to have a website that works, an application process that works. You need to have an outreach marketing effort that gets the word out and gets people to come in. And finally, the thing is you need to have products that are good products. I think the word out was that we actually did a good job negotiating with our partners in the plans. You're also going to have to excuse my pronoun errors. I'm going to use we all the time because I've not been taken. Yeah, that's right. Not that separate. I don't think I'll get away from we for a while. So the products that were made available were at prices that were competitive prices. It was a lot lower than what people expected. I think that reflected a willingness of the health plans in California to accept some of to trust some of the risk adjustment mechanisms, but also a trust that we were actually going to be able to launch the thing and get enough people to sign up. So some of the slides I'm presenting have Covered California logos in the corner. It's because I ripped them off from board presentations from Covered California. This happens to be January's presentation. If you go today, there's another board meeting going on, and there's a new set of these slides going up, and they will tell you the end of January number situation. Mid-January, we had 625,000 people signed up for plans through Covered California. If you look, that's about 85% of those were getting subsidies, 15% non-subsidized. And as Toby mentioned, this is back to the end of the December enrollment numbers. We had 1.2 million at the end of December of people signed up for Medi-Cal, including the 630,000 of the low-income health programs who were transferred in January. Vigorous excellent enrollment numbers. One of the things that we did in California, we did not use the CBO estimates in establishing our goals or our internal goals, and we didn't actually publish very broadly our external goals, although we did in our sustainability model, which is our financial model for supporting the exchange in the long run, project what we thought, three scenarios of what we thought enrollment would be. We had a low scenario, which was Disasterville. We had what was called a base scenario, which was the enrollment pattern that was the UCLA and UC Berkeley in their own microsimulation model projected to be the enrollment path. And then we asked them to see if we jacked up our advertising campaign, how high could it go, and they came up with what was an enhanced level. This compares the base level of total enrollment and subsidized enrollment with the actual year-end, December 31st enrollment numbers. And you can see we're about 86 of the way to actually what was the end of March base number, which was about 580,000. As you saw, in the middle of January, we jumped over that number and we hit 625,000. We are now, in the numbers being presented today before the board, we're at 728,000 through the end of January, which means we've blasted through the base enrollment and we're something like 80% of the way to the enhanced enrollment. That is a significant accomplishment, and it's going to be a wonderful foundation for the future. It turns out we're 88% of the way to the enhanced enrollment goal that we thought we would hit, most optimistic sort of projection for the end of March. Now, a little bit of texture here. We've had an issue with how we provide pediatric dental coverage. Pediatric dental coverage is a standalone, separate enrollment process, and we have fairly low enrollment for children in these plans. That's something that's a subject of discussion. Here's the plan breakout for subsidized eligible versus non-subsidized eligible. You can see 66% of the subsidized guys are going to the silver plan. This is reassuring. We were afraid that the subsidized folks might just look on the thing and see what their premium was and pick a bronze plan because it was the cheapest. It was cheaper than silver. For many people, that would mean they wouldn't be able to get access to the extra subsidies you get if you're in the very lowest income range and you would get an enhanced silver plan. And so this indicates that they're actually looking carefully not just at the premium itself, but they're looking at what we put on our website, which is premium plus an estimated out-of-pocket cost to get your total annual cost, and looking at and seeing that silver enhanced plan is cheaper, and they're going to it. Bronze is pretty large because it's obviously the cheapest, other than what we call the minimum coverage plan, which is available only to a limited set of folks. You can see that the higher income non-subsidized group are selecting plans with a bit higher actuarial value, and I would expect that. Those are the plans that are the 80 and 90%, which is more comparable to the kind of employer coverage that's out there. Does the website work? Well, it works for 60% of the people. It's difficult for the other 40%, and some of that is mixed up with the 15% who are non-subsidized. It's relatively easy if you're not getting a subsidy. It's more complicated if you are getting a subsidy. And that includes the Medi-Cal folks. 82% said that they had the information necessary to pick a plan. We're having some difficulties with our SHOP program. We initially had launched a website and allowed people to sign up on their own. It was not functioning well, and it's been pulled down. But SHOP can be applied for directly through paper through agents around the state. Okay, let's look at the next two goals, control costs and improve quality. We'll take them kind of together because really what they are, they're two sides of the coin. I mean, they're a trade-off where you want to get a good balance. One of the core strategies there are two core strategies that Covered California is banking on to improve quality and to control price. One's a consumer strategy, the other is selective contracting strategy. Under the consumer strategy, the idea is if we give consumers a lot of information about their health plan and their providers, that they will actually make choices as they initially sign up and then on an annual basis as they re-up over time to enroll in plans that they like better or are better for them or get the right balance between cost and quality. Now, this presumes that the competitive marketplace is going to actually respond to that and try to do things that will make their plans more attractive to people and that they care about that enrollment ultimately. The second strategy is selective contracting. And here the operating premise is that California has enough of a market presence that it can actually ask its plans to make improvements that have been shown and can be relied upon to make improvements in how health care is delivered, the quality of health care. Not only about what they're paying for it in terms of price, but also how they're enrolling for providers, what they're requiring their providers to do, how they organize the delivery, and so forth. And in selecting plans and contracting and making terms of contracts with plans, to be able to operationalize some of these ideas about better organization and also to twist some arms around price ultimately. Now, that selective purchasing implies that there's this kind of hidden threat, I suppose you'd say. Not working for the exchange, I wouldn't know. But if you don't cooperate, if your prices are too high, if you don't figure out how to deliver more effective care, then you don't get a contract the next year. As we know, and I think that you look at both of these things. First of all, consumers. Do consumers have the ability to make conscious choices that are going to drive a competitive marketplace to make improvements to lower cost? I think that's an open question. I don't think it's really been operationalized effectively anywhere. And so I have that as an open question. I also have the question about whether we can, as a selective, with Cover California as a selective provider, can push innovation. I think that we want to talk about these in a little more detail. These are the kind of information that Cover California will or will not try to provide. Premium prices, obviously, standardized benefit design. This is a core thing to make those pricing comparisons more effective. Plan provider administrative quality, we're doing CAP scores on administrative elements. We're trying to provide a provider network, a detailed provider network online. It's not been successful yet, but that will be an important key. Drug formulary information, ultimately. Provider quality information. What's the quality of the network that's being offered by that provider? And then finally, coverage product enhancements. That is, what plan, will we allow qualified health plans to offer coverage enhancements, extra benefits, health plan memberships and kind of stuff and will they be something that will make people respond? Here's a slide from our last board meeting that talks about the quality rating. These are the LA plans and the seven LA plans that are available, and this is the kind of quality information we're going to have available. Again, this is CAP scores, it's administrative stuff. Some people have 2 stars, some people have 4. Okay, selective provider purchase. Obviously, we want to select on premium. We want to, Cover California will try to push premiums down. Not just push premiums down, but also start looking at costs. What's your cost of delivering care for certain kinds of people? And can you figure out a way to make sure that the cost of care for diabetics is less? You could start getting into the weeds about the cost of providing care for certain subgroups. We standardize cost sharing through the standardized benefit plans. Network adequacy is something that is judged by by health insurers. But we will be monitoring that, monitoring access, monitoring complaints, and that can influence pressure on plans. Inclusion of essential community providers is a criterion. Plan quality measures, provider quality measures, all of these can be used as criteria for selecting or deselecting plans. The last goal is diversity. One of the goals, explicit goals of Cover California Board is to have better access to services and for diverse populations. California is a very diverse population in terms of ethnicity, geography. There are age issues. The lesbian, gay, bisexual, and transgender community is pushing us very, very hard to try to identify those enrollees within our population and find out whether or not there are disparities there. And households with missed immigration status, there's great concern that when one person's undocumented, that they may not sign up, and if they don't sign up, they can't get coverage. So these are things where the board will be sensitive, will be watching. The current problem is our Latino enrollment is way below. If you look at that final column over there, relative to what we think we projected, we were only at 28%, whereas with Asians, 111, with the white population at 93% of what we projected. This is January numbers. February numbers came in. There's been a good growth, and there's better enrollment. I think we're now at 40% of projected for Latino population, but this is going to be an area of focus for us. Geographically, if you look at the far left, this is relative to the base enrollment. How are we doing in geography? Well, if you look at all of the liberal places of the state, the coastal areas, they're all signing up like gangbusters. But when you look at Northern California, which in this case is the state of Franklin, they're not as enthusiastic in their signing up rates. And that may just be that they just want to take their time up there. I don't know, but I believe that one of our efforts is going to try to make sure that people are in those areas are reached out to. Fresno, probably reflective of the Latino population, lower enrollments. And of course, everybody's watching how are we doing on the the 18 to 28-year-olds or 18 to 30-year-olds. Those numbers are moving up as well. I think we're well into a territory where we are in January. If you look at the January numbers, we've increased that percentage here. And I think we're getting up to our enrollment numbers. Given that we're at the enhanced level, I think that the risk mix issues are going to be able to take a back seat. So here's the last one. Where are we? We had a great first year. The prices and products are really competitive. People are signing up for them like gangbusters. I was not an enhanced enrollment expector. I didn't think we'd be able to hit the enhanced level, and it looks like we're going to actually be able to do it. We're going to be well past base, even if you discount for 20% for people not paying their enrollment. That means we've got the enrollment. We got some. The individual market in California is about 2 million people, so we've got a substantial chunk of the individual market enrolled in Covered California plans. It means the Covered California can put an incremental cost on the premiums that's small enough not to add significantly to the cost of the premium and be able to maintain itself. So what about year 2 and beyond? Well, first of all, this fall, and I don't know whether they could squeeze it anymore, they're talking about an open enrollment process that's only minutes long, starting in the 15th of November and ending on the 16th, or was it they're going to extend it all the way to December 15th? That's going to be a big thing to do and to prepare for. And if there are a lot of people new to open enrollment stuff, it's going to be a great learning experience. Dental coverage, we are changing our dental coverage approach to allow embedded dental plans in an entire plan that you sign up for, so that we'll get better coverage for children. New entrants, new qualified health plans. Do we want additional plans beyond the 11 that we have? And we are actually, the board today, I think it's going to be voting on a policy that we're actually going to open up to Medicaid managed care plans, as well as newly licensed plans. Any plan with an existing license in California would not be allowed to come in. Standardization of benefit designs, they have to be revised because we have a new round of the actuarial calculator, and so they all have to be calibrated to make sure they end up at 70% or 60% actuarial value. We're not going to make wholesale changes in the benefit design. Beyond that, updating the calculator and then dental coverage included in the thing. And then finally, one of the most exciting areas is what Toby mentioned earlier, that the coordination of benefits between the exchange and the Medicaid program, where people can be covered by both. We want it, or when people are moving from one to another, Opening up for Medicaid plans allows us to have it so that when somebody's income goes up, they can have continuity of coverage through their coverage entity and probably continuity of treatment through the same provider networks. That is important. It's also important that, for example, for pregnant women who can have WRAP benefits in the Medicaid program, they can wrap around a Covered California program. But more fundamentally than that, I think is what Toby alluded to, is this idea that the coverage and elements of Covered California and the coverage elements of Medi-Cal really are going to start merging together. Over time, more Medi-Cal plans are going to be offered in Covered California, if not as an initial choice, certainly as a bridge plan. And that'll make the distinction between the two programs ultimately, I think, less significant than it has been in the past. And it's a really, for me, as a former director of the Medicaid department in California, I think it's an exciting time. And I think also for the provider community, it's an exciting time, particularly if you embrace those diversity issues. Because one of the big reasons that we have problems with diversity is because of the differences in financing and access and network availability of the Medicaid program versus the rest of the program. And so that's a conclusion of my remarks.
Thank you, David.
Thank you.